Well, thanks so much for being here, everyone. I'm really excited to be co-presenting with the lovely Marissa, who I'll introduce shortly, about this topic, about an allied health approach to endometriosis. So for those who don't know me, my name is Stefanie Valakas. I'm an accredited practicing dietitian and nutritionist. I have a Master's of Nutrition and Dietetics from the University of Sydney, and I am the founder of The Dietologist, which is a virtual nutrition practice. I'm based in Sydney, but we consult with clients all across the state, the country, and the globe. We have a real passion for reproductive health, especially endometriosis and preconception, fertility, and pregnancy health. And I've been very fortunate enough to collaborate with Monash IVF, CD Fertility, and IVF Australia. Now, Marissa, I might get you to hop on and introduce yourself before we get stuck into the overview of today's webinar.
Hi, my name is Marissa Joseph. I have a Bachelor of Physiotherapy and I'm the lead physiotherapist at Sydney Women's Physiotherapy, which is a pelvic health-based clinic at Bella Vista. I know the name does say Women's Physiotherapy, but since naming ourselves, we have amalgamated further to incorporate all forms of pelvic health. My own personal interests include the management of pelvic pain conditions, pelvic organ prolapse, incontinence, children's continence, and troublesome hip pelvic back pain that has not resolved with management from traditional musculoskeletal physiotherapy. I'll leave you back to Steph.
Thanks, Marissa. So in today's webinar, we will be covering a variety of different topics. So I'll be taking you through understanding endometriosis and its symptoms, just for some background, the importance of multi and interdisciplinary care, the key guidelines around diet and endometriosis and the research to date, key dietary patterns and commonly asked questions around diet and endo. And Marissa will be covering the physiotherapy portion, including common complaints and therapeutic approaches to endometriosis symptoms and concerns. And I will touch base on utilising the chronic disease management care plan to access services via the GP pathway. We'll discuss a few case studies and hopefully have some time for Q&A. We're being really ambitious with what we're covering today. Here are the learning outcomes for your reference. For the sake of time, we'll leave that there. So endometriosis is a chronic inflammatory condition that typically affects the pelvic region, but it is known to migrate to various parts of the body beyond just the uterus and ovaries. It can end up in the bowel, the bladder, and there's even been cases where endometriosis has been found in the lungs and even further away. So it really is, whilst falls in the class of gynecological conditions, it really is a whole body disease, and particularly with the symptoms that we see people presenting with, like pelvic pain, pain with urination, bowels opening and sexual intercourse. We often see altered bowel habits and nausea, heavy menstrual bleeding, fatigue, and much, much more. So some of these can be present, some can be absent, and everyone has a very unique symptom presentation, which can really create a delay to diagnosis, as we know. And I think one of the biggest things that we often talk about, well, I certainly do in my virtual clinic, I'm sure you do too, Marissa, is the endometriosis stage, which is diagnosed via laparoscopy surgery, does not necessarily correlate to the symptom profile or the pain or the severity of those symptoms, which can make it so tricky to understand. We know that 1 in 9 females of reproductive age have endometriosis, which has recently been revised from 1 in 10. And unfortunately, we just do not know the cause of endometriosis yet. There's multiple etiologies proposed, from immune and autoimmune dysfunction, whether the gut microbiome has a role to play, retrograde menstruation, which has been mostly ruled out as a potential cause of endometriosis, environmental pollutants such as exposure to dioxins and BPAs and phthalates and other endocrine disrupting chemicals. We also have genetics and family history. And there's also a hypothesis around longer exposures to estrogen. So earlier onset of menarche and later onset of menopause potentially being related to an increased risk of developing endometriosis. And sadly, there is no cure for endometriosis, so management is absolutely crucial to optimize quality of life as well as fertility if that is desired. So in recent times, I would say we're starting to evolve away from this model of surgical excision via laparoscopy, medications, and contraceptives being the only options for management for endometriosis. And we're starting to view it more as a interdisciplinary approach with multiple potential key team members and approaches that could be valuable. And not all of these could be, at play for each individual client or patient, but they could be considered at different stages based on presentation and goals. So we still have surgical excision, we still have medications, we still have contraceptives, but we're also talking about exercise and psychology and seeing a sexologist if there's sexual dysfunction at play, pelvic physiotherapy, the benefits of acupuncture have been shown for endometriosis management, dietary support for inflammation management and gut symptoms, Botox therapy for the pelvic floor, and seeing a CREI or a fertility specialist advice when preparing for pregnancy. So really kind of expanding that view of how we manage endometriosis. And this has certainly been proposed in some new literature. So a multi or interdisciplinary team could include medical team, so a great GP, a gynecologist, an endometriosis surgeon, potentially fertility specialist if that's required, a dietitian, a pelvic physio, an acupuncturist, and mental health support. And even a pharmacist can be quite a crucial team member of the interdisciplinary team, particularly when we have lots of medications and supplements and things kind of interacting with each other. It's really important that a great pharmacist is on board to review any of those things as well. So I just wanted to point out a couple of quotes that kind of supports this idea from some of the most recent literature. So this is a quote from Leonardi's paper published in 2020, which certainly garnered a lot of attention from the medical community and as I think the media as well. And so this quote really resonated. We believe that care management by a multidisciplinary team of dedicated and specialized healthcare professionals will lead to improved outcomes, including improved quality of life for people living with endometriosis. And this one is from another paper in 2017. Endometriosis is a chronic condition and an integrated approach involving a multidisciplinary team is essential in optimizing patient management. It ensures that a full range of therapeutic options are considered early so patients receive appropriate and timely treatments. So the question I'm often asked by my colleagues is, Steph, can diet really help with endometriosis symptoms? And I certainly wouldn't be filling in a 1-hour presentation if everything pointed to no. But I just thought I would point out the new RANZCOG guidelines about endometriosis. So in treating people with endometriosis, these specialists could include gynecologists, nurses, pain management specialists, colorectal surgeons for bladder, bowel, and ureter involvement, psychologists, pelvic health therapists, physiotherapists, and dietitians. There was also some caution against particular diets and herbal medicines because of uncertainty about interactions and concerns regarding side effects and lack of supporting evidence. Now, I will say there is certainly no one universal perfect diet for endo, and nor is there a single quote unquote endo diet, which I often hear clients reporting. They've been told to follow some kind of endo diet from something they've read online, but it simply just does not exist. Interestingly, this qualitative study from a research perspective, which was 12 participants, but I think the benefit of qualitative studies is not so much in the number, but rather the richness of the data that we get. And participants noted an improvement in well-being and a reduction in symptoms following self-initiated diet and lifestyle changes. So many of these were not guided or supported by a dietitian. And In particular, the participants stressed the lack of support from healthcare professionals. And anecdotally, clients are often self-referring, I will say, and wishing that this option was offered to them sooner to help them take control of their own circumstances for what is otherwise what we know is an incurable disease. So when we talk about diet, most of the research has been focused on risk factor for endo. So what dietary elements do we know may increase the risk of developing endometriosis, which I guess is a bit of a different lens to look at it. However, that can kind of be applied to people that are already living with endometriosis and are trying to avoid potential further exacerbation or worsening of symptoms or progression of disease. So in this 2017 study distinctly showed that things that increase risks include dietary trans fats, fruit, I'll circle back to this in a second, and red meat. Now, fruit is an interesting one. You'd think that fruit, surely, given fiber and micronutrient content and antioxidants and the like, would reduce the risk of developing endometriosis. But interestingly, we think that potentially fruit in particular, where we consume the skin of many fruits, think apples and pears and whatnot, it's really actually about the pesticide exposure rather than the fruit itself, which was kind of conferred in some other studies. Reduced risks were associated with dairy foods because particularly their contents of vitamin D. And I just saw another study pop up in my PubMed alerts yesterday supporting this. Again, that dairy food intake, particularly full fat, seems to reduce the risk of endometriosis. B group vitamins and vegetables and antioxidants, as well as fiber, healthy fats and fish oils. Now, things that had insufficient, contradictory, not enough evidence found were alcohol, soy and phytoestrogens, and caffeine and coffee. Now, we know that diet and inflammation is a very hot topic at the moment. And I think the tricky thing with this is sometimes, particularly patients, can get really laser focused on single foods. And it is this food inflammatory or not inflammatory? Is this food inflammatory or not inflammatory? But we really need to help them zoom out and realize it's about the dietary pattern overall. So if the dietary pattern focused on adequate fruits and vegetables, herbs and spices, unsaturated fat sources, omega-3 rich fish and seafood, legumes and beans, whole grains, dairy foods, full fat preferably, coffee and tea and dark chocolate, which are all rich in polyphenols, then we're doing a great job from a dietary pattern if they're doing that most of the time. If they're limiting these things most of the time, then we also know that that's also positive for balancing out that pro-inflammatory, anti-inflammatory ratio. So things we want to limit, but not necessarily completely eliminate because, hey, we still got to live our lives, right? Things like alcohol, saturated and trans fats, excess added sugars, burnt or blackened foods such as burnt toast and char-grilled meats are high in advanced glycated end products who've been associated with both fertility concerns as well as endometriosis. Red meat in excess and processed meats, which we know from the WHO guidelines are best to be limited as well. So each individual client is probably going to have their own unique sensitivities and thresholds to each of these things. Some people can't get away with a single glass of alcohol and others can. And so that's really where a dietitian can come in and help support and help navigate them through that so that they can understand their thresholds and also have a really flexible dietary pattern that supports their disease whilst also maximizing flexibility in their social life. That is also critical when it comes to quality of life, am I right? So, like I said, no single food is inflammatory. It's really about dietary pattern. Now, I want to talk about endometriosis and irritable bowel syndrome. So IBS affects about 15% of the population, and women are more likely to be diagnosed compared to men. Women with endo are actually 2.5 times more likely to be diagnosed with IBS. And it's likely due to some overlap in symptoms such as bloating, constipation, gas, diarrhea, and alternating bowel irregularities in particular. And it can be tricky to, I guess, define the line between what is endometriosis related, particularly if no surgery has been done of late, and what is IBS. And many clients really struggle to untangle that themselves, and it is challenging. So I guess what are the commonalities? Low-grade chronic inflammation and visceral hypersensitivity, that hypersensitivity of the nerves that are innervating the abdominal region, and also their sensitivity to the amount of gas being produced compared to the next person who doesn't experience visceral hypersensitivity. We also know that IBS is one of the top misdiagnoses prior to getting a diagnosis of endometriosis, and many symptoms actually, once endometriosis is identified, diagnosed, and excised, can actually remit once surgery is performed. However, if it doesn't remit, I think this is really where an evidence-based diet and lifestyle approach can make a big difference. So a low Fodmap diet, which as we know has been developed by Monash University, is a short-term diet to help manage the symptoms of IBS and identify the unique triggers. So the first step is to reduce Fodmap load in the diet, which are fermentable carbohydrates. As some people with IBS have trouble digesting these particular sugars in the small intestine. They end up in the large intestine and they are rapidly fermenting, producing excess gas, and also they have an osmotic effect. So water gets dragged in and we get a change in bowel consistency and frequency. In those who have both endo and IBS, women report a 50% improvement in symptoms using the low Fodmap diet. However, it is not a long-term approach. And I really stress that if this is something that you and your patient or client are considering, please refer to a dietitian. There is a lot more support that is needed than meets the eye when it comes to the low Fodmap diet. And we know that people are on it for fewer weeks, experience better symptom improvement, and are less reliant on really expensive products when they are actually working with a dietitian on the low Fodmap diet. So that's really crucial. Now, thinking a little bit less about IBS specifically and more about just the gut microbiome in general. Research is beginning to show that the microbiota profile of those with endometriosis and those without are distinctly different. We're talking different strains and phyla and so on. Gut flora is implicated in estrogen metabolism, and we know that endometriosis is an estrogen-linked disease. So the ones that we need to be particularly mindful of are the flora that are producing the enzyme beta-glucuronidase. Now, beta-glucuronidase is that enzyme which can deconjugate already conjugated estrogens, which has either occurred in the liver and has come through the hepatic portal system towards the gut, leading to reabsorption into circulation. And this has been studied in other estrogen-linked conditions such as breast cancer as well. So we think that the gut has a particularly interesting role to play with endometriosis. We haven't fully fleshed it out yet when it comes to the research. You can see it's very recent, but I think this will be an area of evolving interest in the coming years in the research, and potentially a way for us to maybe even diagnose or be able to categorize people with higher risk of being diagnosed with endometriosis via laparoscopy later on, maybe using something like a stool analysis is my thinking from this research, but it'll be interesting to see how this space evolves. Now, what are some take-home messages when it comes to endometriosis and the gut microbiome? Well, we want to maintain regular and healthy bowel function. This is really important. So adequate fiber and fluid movement, being less sedentary, which I'm sure we all are a little bit guilty of at the moment in particular, and treating any IBS or endo-related bowel dysfunction for both the GI symptom profile and to ensure that the bowels are working, that the stool isn't getting stuck in the bowel for long stretches of time, and that beta-glucuronidase potentially then deconjugating that already conjugated estrogen. So that's really important. And also for just general health and well-being anyway. Probiotic therapy may be helpful, but this is really on a case-by-case basis, and we don't yet have enough data to know what strains and dosage are most beneficial for those with endometriosis, but we can apply some of the knowledge that we have in the IBS field to this arena if it's appropriate to that particular client symptom. So I wouldn't just blanket recommend, hey, go take a probiotic from the pharmacy shelf, you'll be right. Because for some people, probiotics are either not effective or exacerbating their symptoms. Now, what about endometriosis and infertility? Can diet play a role here? Well, 30 to 50% of those living with endo have subfertility or infertility. Those with infertility are 6 to 8 times more likely to have endometriosis than those who are fertile. So many of my clients are never diagnosed until they're experiencing a delay to fertility, and they were pretty much asymptomatic or believed that their symptoms were in the realm of normal when it comes to their period and the pain that they were experiencing. So management strategies, again, include laparoscopy and excision, supportive fertility treatments. So I've seen cycle tracking, progesterone therapies, IUIs and IVF, as well as ovulation induction have all been part of different care plans. So here's that 30 to 50%. So it's pretty high. Now, here's a quote from me. And this is certainly something that I see amongst my clients who maybe aren't trying to conceive right now, or, would like the option one day, but it's not an immediate goal. And I think the key message that they always tell me that I try and advocate for is, irrespective of fertility goals, current or future, diet and lifestyle strategies are important to offer for those with endometriosis who are interested in nutrition as an approach, because if they're not interested, I can't eat the food for you, would benefit from dietetic advice. So if they're having persistent bowel issues, they're coming up with nutrient deficiencies like iron, B12, vitamin D, and or they just feel like they've exhausted other options and they're not getting the improvement that they hope to with the current options at play, prioritizing quality of life for those with endometriosis is still really important, and diet can play an important role in that for them. Now, I want to talk about some of the key, nutrients, components or food components that seem to come up time and time again from clients, because if I'm getting these questions, I am pretty confident as primary healthcare providers, you are too. So gluten and endometriosis, what's the go? So the gluten-free diet has only ever been studied once or twice for those with endometriosis. And it was back in 2012, 207 patients with endo. They went gluten-free for 12 months in Italy, mind you. So a particularly interesting cohort. 75% reported a significant change in symptoms and improvement, and 25% reported no improvement but no worsening of symptoms. So we got a 3/4 improvement, basically. Considerable increase in scores of physical functioning, general health, vitality, social functioning, and mental health in all women was noted. Now, the question is it the gluten, or is it actually potentially the fact that gluten-containing grains such as wheat, barley, rye, actually are high in fructan, which is a highly fermentable carbohydrate and also a FODMAP. And so I guess the question therein lies is, are they also reacting to other high FODMAP but naturally gluten-free foods such as honey or onion or cashews or kidney beans or cauliflower or raisins or mango or garlic, or, there's a whole bunch of high FODMAP gluten-free foods, but just some examples. And there's also a whole bunch of low FODMAP foods that also contain gluten. So we can get small amounts of gluten-containing pasta, we can get spelt bread, we can get some grains that are gluten-containing but are low FODMAP. And then we've got a combination of both low FODMAP and gluten-free, like white rice and brown rice, quinoa, corn, for example. So it becomes a question of, was it the gluten, the protein fraction, or was it the carbohydrate? And we're not quite sure based on that study, but it is an interesting area to explore on a case-by-case basis for clients. What about soy? Remember, we had that contradictory, unequivocal evidence in those previous studies I mentioned. So soy foods contain phytoestrogens that are naturally occurring estrogens that can weakly mimic estrogen in the body. And I think people probably overstate this in their minds when they are looking at information about soy and hormones in particular online. Now, there has been inadequate research to really connect soy intake with endometriosis. Some benefits are seen with soy intake and endometrial cancer, which is again another estrogen-related concern, but we haven't been able to see it as clearly with endometriosis. Now, there was some research about urinary concentrations of phytoestrogens in one study, and it showed a higher concentration of phytoestrogens was linked to having more progressed endo, so stage 3 or stage 4, but not 1 or 2. Now, particularly for vegetarians and vegans in particular, not having soy as a protein source, which is a complete protein, and if you have any kind of gut sensitivity to legumes and beans, leaves you with very, very few high quality protein options. So we need to be really careful about the baseline diet and their intake of soy if they are choosing to reduce or abstain from soy foods for whatever reason. So when consumed, which can be consumed a few times a week pretty safely, choosing unrefined sources like edamame, tofu, and tempeh over highly refined things like soy sausages and burgers and other meat alternative products, which are more refined. So going towards those more traditional sources is ideal. What about red meat? We seem to see an increased risk with red meat intake. It's pretty controversial in the research, actually, and particularly amongst those with endometriosis, as well as seems to be that small amounts of unprocessed red meat that's really lean a couple times a week or once a week seems to be fine for most of my clients, at least. From a research perspective, it seems to be that the less, the better. But then comes the question of iron deficiency is far more likely, particularly amongst those with heavy menstrual losses. So how do we kind of compensate for that? And that's really where a dietitian can help support with around other ways to achieve iron adequacy, and also to discuss supplementation as appropriate that minimizes GIT upset as well. So suggestions of intake being once per week or less, as I said, came from this study, and likely due to saturated fat content being the biggest player, perhaps also due to cooking methods and the formation of advanced glycated end products that also comes along with red meat. So again, crucial for us to make sure that we're monitoring ferritin, and we're also making sure that diet is optimized for iron intake, particularly when we are seeing symptoms of iron deficiency or we know there's heavy bleeding in the history. So does the Mediterranean diet really apply here? Well, yes. I mean, what context doesn't the Mediterranean diet apply? So the foundations of the Mediterranean diet are really around being engaged with food and socially engaged, cooking and shopping, at daily movement and so on, having plenty of seasonal veg, legumes and beans, whole grains, extra virgin olive oil, herbs and spices, nuts and seeds, proteins being fish, seafood, legumes and beans again. Less commonly eaten is your poultry, eggs, cheese and yogurt. Red meat and sweets are occasional. Red wine is enjoyed with food and with people in moderate quantities, and drinking lots of water. Now, there has been some unpublished data from 2011 suggesting that Mediterranean diet compliance amongst those with endo resulted in a significant reduction of painful periods, painful sexual intercourse, and difficult to pass stools, likely, I suspect, due to the improvement in fiber intake compared to, say, a standard Western diet. And when it comes to fertility, we know that Mediterranean diet is a winner. We've seen that in a couple of Greek fertility clinic studies, and amongst both men and women across all BMI ranges in men, irrespective of actually things like smoking status. We saw an improvement in sperm concentration, motility, progressive motility, and morphology. And amongst females in a healthy BMI range with better adherence to the Mediterranean diet, had significantly better clinical pregnancy and live birth rates. Now, I want to talk you through a case study before I hand over to Marissa, whilst your brains are thinking about diet and endometriosis, and then I'll come to your questions at the end of our talk. So I wanted to highlight a non-fertility related case for you. A lot of what we see is fertility related in our clinic, but we do see a lot of people who are newly diagnosed with endo where fertility is a distant goal. So I wanted to highlight how we could assist. So Miss F comes to me, 17 years old, referred by her gynecologist. She's newly diagnosed with endometriosis and ongoing diarrhea issues. She does have a lot of stress. She's at a top selective school with the upcoming HSC. Endo has left her attending very little of school and resulting in social isolation, starting to affect her mood. She was in attendance with a very anxious and apprehensive, but loving and caring mum who had lots of questions for me. And we decided that whilst it was going to be a little bit challenging, given everything else that was going on in Miss F's life, to commence a low Fodmap diet for 2 weeks to see even if that could help with her ongoing diarrhea issues, because that was having such a significant impact. But I also talked to her a little bit about the impact that her mental health and her stress was having on her gut as well. But it was kind of like a bit of a vicious loop. She was really stressed because she was missing out on school because of her symptoms. And so round and round we went. So I thought, okay, let's try and intervene here and see what we can do. So within that 2 weeks, she had a significant improvement in her diarrhea symptoms and reduced generalized pelvic pain. However, she was losing weight and was not managing well with alternative options, with little nutrition knowledge, because she was living with her non-English speaking background mum and grandfather, and they were kind of having a bit of trouble doing the substitutions despite my education. So the next time I saw her, we troubleshot dietary issues, provided more simple meal ideas, product suggestions to kind of make it more convenient, and made sure that energy intake and nutritional knowledge was adequate. And we also safeguarded against constipation, which can sometimes happen if low FODMAP fiber intake is suboptimal, with kiwi fruit as well to a day. So pretty quickly, Miss F was able to return back to normal hours at school. We worked out her key FODMAP triggers by going through the challenge process systematically, and she ended up experiencing sustained success using this approach to help manage both her endo and IBS, and we incorporate some anti-inflammatory principles along the way. So from my section, just a few take-home messages. From me, if this is all you get out of my talk today, I will be really thrilled. Endometriosis is a chronic lifelong condition that requires an interdisciplinary team approach. An endometriosis experienced dietitian can help with reducing estrogen, inflammation, and managing gut symptoms in women with endometriosis, as well as optimizing the diet for fertility, energy levels, and nutritional status. No one should implement self-initiated dietary restrictions such as gluten or dairy or red meat or low FODMAP without a consultation with the dietitian, as this may result in inadvertent nutrient deficiencies such as iron, zinc, iodine, fiber, calcium, B12, and so on. So we don't want to do any harm during this process, and we want to have a liberalized diet wherever possible. So I'll hand over to Marissa now to talk all about physiotherapy management, and then I'll hop back on to talk about care plans and to take your questions.
All right, hi. So we're going to talk a little bit how physiotherapy can help manage endometriosis. Now, I really struggled putting this content together, to be honest, because physiotherapy is quite diverse and quite broad with how we would manage endometriosis. And it really does vary depending on the type of patient, their concerns, and also their goals, whether they want to be sexually active or whether they want to play sport, whether they, what the demands of their work are, and so forth. So there is a lot of different treatment methods that we may have, and it's about bringing those tools together to tailor individualized programs or tailor individualized treatments depending on them. So I've tried to streamline it as much as possible to present to you kind of a picture of how we would manage the overall picture, but please know that that is not the only ways that we may manage things, and it can go beyond as well. The other thing to note as we are going through the presentation, unfortunately, with a lot of women's health, research, in particular with endometriosis, is poor. And so what we find with the research is that there may be some research to support one mode of therapy, but it doesn't actually look at how the modes of therapy come together to look at the big picture. And so often those research papers, when we're looking at management from a physiotherapy point of view are a little bit skewed as a result, because we're not looking at it from a holistic point of view, which we're very proud of doing at Sydney Women's Physiotherapy. So Sydney Women's Physiotherapy is a practice of physiotherapists who have over 40 years of combined experience. We are a specialty pelvic health clinic located in Bella Vista opposite Norwest Private Hospital, and have been servicing the communities of the Hills District, Western Sydney and the Hawkesbury for 12 years. We don't just service those areas though. We are actually in really good connections with doctors from the Women's Health Research Institute of Australia, and so often we are getting referrals from those doctors as well. So we do get patients travelling quite far to come and see us, because we are one of the larger women's health specific clinics within Sydney, but we are not the only ones. So what are some of the complaints presented in clinic? It would be pain with intercourse, pain with urination and or defecation, urinary frequency, urinary urgency, incontinence, whether it's stress incontinence or urge incontinence, less of fecal incontinence seen with endometriosis, IBS type symptoms, abdominal bloating, pelvic pain, hip pain, lower limb pain, burning, numbness, pins and needles in the vulvo-vaginal area and or extremities, irritation to clothing and or underwear, and fatigue. Next slide, Steph, thanks. So what are some of the goals of physiotherapy? We want to improve bladder and bowel health, improve sexual health, improve movement patterns. So in terms of gait, sit to stands, lifting, twisting, running, things like that. Provide tools for pain management, reduce opioid use, which is huge. Assist in helping patients balance work, social and fitness activities, and really importantly, assist in the collaboration of all health professionals. So trying to get everyone to work together as a team. So a little bit about the anatomy around the regions that we look at, which I think is important to note, because it will make a little bit more sense about how then we approach it from a physiotherapy point of view. So the pelvic nerve is from the nerve roots S2 and S3. Hypogastric nerve is from L1 and L2. Pudendal nerve is from S2 and S3. Ilioinguinal, is from the lumbar nerves. Genitofemoral lumbar, posterior femoral cutaneous is from the sacral nerves. So when we think about managing our patients, often we think about a visceral convergence. So what that means is that inflammation in the viscera, such as inflammation in organs like the uterus or inflammation in organs like the bladder, can cause inflammation which results in hyperalgesia and overactivity in viscera with the same nerve root supply. So if the uterus is causing any kind of inflammation, hyperalgesia and overactivity, we may see symptoms in the bladder as a result of the symptoms within the uterus. This is a result of noxious afferent signals from visceral disease converging with other visceral afferents in the spinal cord, leading to a release of inflammatory neurotransmitters by afferent nerves into alternate visceral structures. So this is why we often see endometriosis, irritable bowel syndrome, and bladder pain syndrome linked in so many patients. It's often a triangle that we can see in a lot of them. And then we want to look at it as well from a viscerosomatic convergence. So it's the same concept ultimately, but this is more where the visceral afferent noxious signal converges with the somatic afferents in the spinal cord, meaning that messages are then sent to skeletal muscle. So what that results is inflammation, hyperalgesia, and overactivity in somatic structures of the same nerve root supply. So what's the result of that? Muscle spasm, muscle pain, and muscle guarding. So the two types of pain that are generally explored, but most commonly seen in practice would be the central sensitization. So central sensitization is increased responsiveness of nociceptive neurons of the central nervous system to their normal or subthreshold afferent input. And peripheral sensitization is increased responsiveness of nociceptive neurons of the peripheral nervous system to their normal or subthreshold afferent input. So peripheral sensitization, you can think of it as you've had a sunburn and you get into the shower and you turn the water on and then it really hurts. And the reason behind that is because your body doesn't want any more exposure to heat, whereas central sensitization, usually symptoms are parallel between left and right side. They're a little bit more vague, and it won't necessarily be as a result to an external input. So in terms of just breaking it down a little bit, so as you can see, there's a lot of overlap with how we would manage our conditions. There's a lot of overlap with symptoms as well. So in terms of managing urinary frequency, urinary urgency, IBS type symptoms, and keep in mind, IBS definitely can be a true cause of problems, but sometimes people, some people with endometriosis, their cause of constipation ongoing that you may be thinking might be a little bit of an IBS type constipated end of it. It might actually be what we call obstructed defecation, which is where, because their pelvic floor muscles may be guarding, you're actually not able to pass the stool through effectively. And so the patient might be presenting as constipated and pain with urination and or defecation. We would address those symptoms with fluid intake, dietary modifications, very basically. So I'm talking, you know, we would just give them general fiber advice, maybe, you know, encourage them to have Movicol, try Movicol for a period, or any other kind of stool softener, steering clear of metamucil if possible, because it's typically a bulking agent. So those kind of advice, as a lot of as well constipation can result in urinary symptoms. So we would address it quite simply, but if it was beyond our scope and someone had a lot of dietary concerns or a lot of other symptoms such as abdominal bloating and things like that associated with it, we would definitely refer on to a dietitian, and Stephanie's are a dietitian that we use a lot. And demonstration of correct voiding and defecation positions and techniques, including the use of a squatty potty, and then management of the pelvic floor. In terms of management of symptoms such as dyspareunia, vaginismus, burning, numbness, pins and needles in the vulvovaginal area, irritation to clothing and or underwear, pain with urination and or defecation, we would look at the management of bladder and bowel health. Make sure, you know, the bladder and bowel are going frequently as you would expect. and nothing out of the normal with that. We may trial electrical stimulation either vaginally or transcutaneously to address some of the neural symptoms, to bring down the neural response. Sexual education is really important. That includes education around sexual positions. So some positions may actually make patients' dyspareunia worse, and some positions may make it feel a bit better. So having these really open conversations with patients is important. Also in terms of anatomy, so talking patients through anatomy, a lot of the time the female anatomy can be quite taboo depending on the way the patient has grown up. So you know, talking through what are the components of the vulva, the vaginal tissue, the clitoris, and things like that, and how can we use that tissue and overcome some fears that might be creating vaginismus can be important. And importantly, pacing strategies. We would, in terms of symptoms such as abdominal bloating, back, pelvic, hip, limb pain, and fatigue, we would use therapies such as manual therapy, so soft tissue releases, trigger point releases, joint mobilizations, and so forth. Because keeping in mind about the convergence, if we work from a muscular point of view, we may get a result at the visceral level, and if we work from a spinal level, we may get a result either at that muscular level or at that visceral level. So applying some of those manual therapy techniques, we would apply some muscular strength and endurance. And sorry, questions have popped up, which has changed my screen a little bit. Stretching as well, and again using TENS machines, but transcutaneously, so external, to address some of the neurological pathways. And management of the pelvic floor. So management of the pelvic floor is an overall theme for most of it. So in terms of management of overactive or hypertonic pelvic floors, they are generally what type of pelvic floor we will see with an endometriosis patient. And there is a difference between an overactive pelvic floor and a hypertonic pelvic floor. So an overactive pelvic floor is a poor ability to relax the pelvic floor, i.e. that pelvic floor is always switched on. So in a way that if this is your arm relaxed, your bicep is relaxed, and this is it fully contracted, they might always be walking around with their arm here because their bicep's just always on. In contrast, a hypertonic pelvic floor is a rigid pelvic floor. So it's very stiff, it has a lot of muscle bulk, lots of tone. The approach will vary that we take depending on whether the patient has an overactive pelvic floor or a hypertonic pelvic floor. And as I said before, there is no one way to approach these concerns, but rather a multitude of variations to address the patient's individuality and level of tolerance to therapy. So the two main things when we think about managing overactive or hypertonic pelvic floors are dilators and TheraOnes. Dilators are probably, as primary healthcare providers, you may be familiar with. Lots of people are aware of dilators. TheraOnes, probably not so much, but I have a close heart to a TheraOne. They're quite good. So dilators are more commonly used for hypertonic pelvic floors, so those rigid, lots of tone pelvic floors. They are targeted towards achieving the goal of penetration, generally as a result of vaginismus through graded exposure. So we would look at using dilators for someone who either has never been sexually active before and finds that they've got true vaginismus where the they're getting just that guarding on any kind of penetration. So as the dilators start to become a little bit bigger, it's that graded exposure to stretch so that eventually they can achieve some level of penetration, ideally full penetration of a penis if that's what the patient desires. But everyone has different goals. Some patients' goals may just be to use a tampon, and that's okay as well. The smallest dilator works really well at achieving that goal. Thermones are most commonly used for an overactive pelvic floor, so that poor ability to relax. And that's usually for a patient experiencing dyspareunia. So they can have intercourse, they have space there. It's just that rather they've got quite sensitive tissues. They are a little bit tight in some areas, poor relaxation, and we use it to desensitize the tissue. So get used to a bit of touch, a bit of stretch as well. Trigger point releases through there like you would if you had a tight hip, a tight gluteal muscle in the hip, and you had trigger point releases to address some of that pain and discomfort. You would do that internally as well. And myofascial releases and gentle stretch. Vaginal EMG biofeedback. So the use of biofeedback is really important in assisting with the visualization of the contract and relax components of pelvic floor movement. Not everyone needs this, but patients that are finding it really hard to understand the ability to squeeze their pelvic floor and then how to release and open up. Particularly with those overactive pelvic floors, we would use biofeedback just because then they can visualize it a little bit better. And pelvic floor relaxation exercises. So once the patient understands how to contract and relax the movements, then they can be replicated in a number of positions to optimize not only relaxation, but also start to incorporate function. So different types of yoga poses, squat poses, different hip opening postures are really important to have the patient start to create more space throughout that pelvic region, which often relieves a lot of symptoms. Deep breathing exercises. So deep breathing assists in pelvic floor relaxation through its connection with the diaphragm. A deep inhale will descend the diaphragm as a result of stretch to the pelvic floor. In addition, deep breathing reduces central sensitization through activating the parasympathetic nervous system. So not only does it help relax that pelvic floor, but it also helps manage pain, particularly when in a flare-up. Just slowing down, sitting and taking some deep, slow, meaningful breaths into the lower abdominals can help reduce the experience of the pain at the time. Yoga therapy, I'm quite passionate about yoga therapy. I actually was very lucky to speak at the Continence Foundation of Australia and speak at the New South Wales conference about the benefits of yoga therapy for a physiotherapy point of view. So yoga therapy, oh, I didn't write that underneath, sorry. Yoga therapy often is really important in the way that it incorporates that pelvic floor relaxation. It incorporates the deep breathing and a lot of the stretching of the pelvis, the hips, the thoracic spine, a lot of those structures through the body that often become guarded as a result of that viscerosomatic response and central sensitization. Stability exercises, so incorporation of stability exercises to address any muscle imbalances and or weaknesses is important to reduce the load on the pelvic floor. With poor movement patterns as a result of these concerns, our pelvic floor may compensate, resulting in an increase in tone or overactivity. So if a patient has a really weak hip and every time they stand, they drop into that side of the hip because they don't have good muscle bulk through their gluteus medius to level up through their pelvis. They're actually going to put more load consequently through the pelvic floor. The pelvic floor is already predisposed to be a little bit overactive or a little bit hypertonic. That's just going to creep up that little bit higher and make it even harder for the contract and relax ability to occur, which can result in things like incontinence because it's just so rigid, doesn't move, and it needs to move. Education is really, really important. So education in respect to their condition, symptoms, likely prognosis. So many patients want to know, when am I going to get better? And that's going to be dependent on how much they're committing to their therapy. Also, it's going to be dependent on where they're starting at. Are they starting at a point where they are only having flare-ups during their period? Or are they at a point where their pain is now due to central sensitization every day? So the prognosis is going to be varied, but they want to have a little bit of an answer, and sometimes we can give them a bit of feedback. Sexual education, like we spoke about before, is really important because they're just left with many questions after receiving a diagnosis. I think when they receive a diagnosis in a specialist room, there are many fantastic specialists who do take the time, but I mean, it's so busy in those kind of environments, but we are fortunate enough in a private clinic at Sydney Women's Physiotherapy to dedicate at least an hour for an initial appointment to, even if we just speak to them for the whole hour, to allay any kind of fears, because we are lucky enough to have that time. Advocating for the patient. So often as physiotherapists, we'll advocate for the endometriosis patient by encouraging referrals to a specialist if they're not already under one, and encouraging the conversation surrounding potential use of medications with their GP specialist to improve their physiotherapy outcomes. So I'm sure as primary healthcare providers, you've probably, if you're a GP, been exposed to a physiotherapist at some point, writing you a letter saying, I have this patient and they have pain, even if it might be a shoulder injury, they have pain in their shoulder injury, and unfortunately they can't participate in all of their therapy because the pain in their shoulder is so severe that it's limiting them from moving and doing the therapy that they need to be. We will do similar letters and advocating, but often the medications that we will talk about will be slightly different. So we're talking about more of our neuropathic pain medications because we know this isn't an acute thing. We know it's more long-term and chronic, so we know the neuropathic medications work. And often patients need to be on that to bring their pain down to a point where we can work with them on a physical level and then start to wean off some of the medications. Manual therapy can be used to address any spinal levels that may be affected from T10 to S3. By way of convergence, signals can be sent to the affected tissue, which we've already discussed a bit earlier. So just a little bit of the little bits of research that we do have that advocate for physiotherapy. This research paper looked at GP, physio or sex therapists for the management of vaginismus, and they wanted to know which healthcare professionals women with vaginismus consult and how helpful did they find the consultations. Also, which treatments were typically received and how helpful were they? So the results, women were most likely to consult with a GP, a gynecologist or a GP, and psychologists were generally followed up with a consultation. Gynecologists were rated to be more helpful than GPs, and the most helpful consultations were with physiotherapists. Treatments most frequently received were vaginal dilation, pelvic floor exercises. They did Kegels, typically wouldn't do that in our practice though. Talk therapy, vaginal self-examination, and relaxation training. The treatments that were found to be most helpful were vaginal self-examination, sex education, sensate focus exercises, vaginal dilation, and talk therapy. A systematic review looked at 43 eligible studies looking at the management of provoked vestibulodynia, and the treatments included dilators, electrical stimulation, education, biofeedback, and a multimodal approach. The results were the vast majority of studies showed that physical therapy modalities such as biofeedback, dilators, electrical stimulation, education, multimodal physical therapy, and multidisciplinary approaches were effective for decreasing pain during intercourse and improving sexual function. So just a really quick case study to wrap it up. So patient X, 26-year-old female, diagnosed with endometriosis at the age of 21 years old. 20 years old. They had one laparoscope with excision of endometriosis at 20 years old. And their medications included the Mirena, Zoeli, gabapentin, Topamax, Lexapro, Cicadan, and Mygel, and amitriptyline and estriol cream. Their employment, they were a full-time physiotherapist actually, and in terms of exercise, they did netball, running, strength training at the gym, and enjoyed socializing with friends on the weekend. Their concerns were pelvic pain, abdominal bloating, dyspareunia, fatigue, poor sleep, flare-ups during work and exercise at times, and fainting during work, which was a big problem for them. So the management plan included education, graded exposure to touch and sensation, the use of a TheraWand, focus on pelvic floor down training, stability exercises, yoga therapy weekly to bi-weekly, Pilates weekly to bi-weekly, and removal of strength training at the gym, because it was actually found that the increased resistance was flaring them up, and pacing strategies. The patient also received Botox therapy to the pelvic floor from their specialist that further improved their outcomes with pelvic floor muscle down training. So the outcomes were that they became sexually active with minimal to no pain. They had improved sleep. They started to sleep through the night, less frequent abdominal bloating, no longer flaring up during work, no more fainting during work, and exercise tolerance was increased. So I'll give you back to Stefanie.
Yeah, thanks, Marissa. I will just briefly touch on this before we head into a Q&A. I'm aware of the time, but I did see this question come up. So I think it's particularly important as primary healthcare providers to know about the referral pathways to allied health support with endometriosis. So making a referral. So once you and your patient have agreed that involving other team members is the best next step in their care, you, or if you're a practice nurse or practice manager, the GP at your practice, or if you're allied health tuning in, referring back to the GP, can then initiate a referral as per the team care arrangement or chronic disease management CDM plan, and allocate sessions accordingly to dietitian, physio, and other relevant allied health accordingly, with a maximum of 5 combined per calendar year, as we know. Interestingly, I'm not sure if you've experienced this too, Marissa. Some patients do find it hard to get these care plans for endometriosis alone, although it is certainly in the class of a chronic disease and requiring interdisciplinary care, as we've stated. So yeah, I think it's one of those little hurdles that if we can try to minimize across the board is really helpful in terms of patient care. If those wanting to Utilize private health funds. That's also totally cool and no referral required, definitely on my part, to see me or the team if they wanted to use their extras cover, for example, although always appreciated for a little bit of context and history and any relevant pathology on my end as well. And I'm sure scans and so on might be useful for you, Marissa. So Q&A, let's check it out. I'll field the questions to, can you see them, Marissa? Yeah, beautiful, because there's one in there where I definitely will not know how to pronounce it for you.
Yeah, I've seen the one.
Yeah. Do you want to answer Suzanne's question?
Yeah, sure. So when we're looking at it from
I might just read the question for the recording.
So
with pins and needles in the vulva area, would you not want to exclude cauda equina issues? Sorry if I butchered that.
Cauda equina, yeah.
Sorry.
So with these kinds of patients, I think that it's more important to acknowledge that they are likely to have they wouldn't have pins and needles. So the pins and needles in that area probably wouldn't be relevant, but they definitely would have numbness, burning sensations. The pins and needles might be more relevant to soles of feet because of the around S1, S2, those kinds of areas of the feet. So sorry, I think that presentation was a little bit blurred, but in terms of anything around the vulval area, I think it's quite easy to not think about cauda equina first, just because it does match their whole picture. I think if someone was coming into the clinic and they were presenting with these symptoms and they had no other concerns that would even put into your mind a reason why, 100% a referral would be needed. But it is so common for these patients to feel a burning or a neural symptom vaginally just because of the pattern. And when you look as well in terms of bladder and bowel health and you rule out some of those other questions in terms of incontinence and emptying, because we're asking many questions throughout our consult in terms of how are they emptying their bladder, bowels, all of those functions, you can kind of understand that it's very unlikely to be that. And I don't know any colleagues or any even specialists that in that pain management side of gynecology that have been stuck with that. So I think, it's that little bit of clinical reasoning from that point of view. I hope that answers it.
Thanks, Marissa. I have a question here. Thank you for the high quality and interesting presentation. Oh, thank you for the kind feedback. Please leave that in the feedback form. I mentioned probiotics. I did. Any recommendations for yogurt variations best for probiotic content? Yeah, I mean, when it comes to yogurt selection, choosing a yogurt that has the live cultures listed on packet, like on label, is probably the best option, which is most brands. Obviously they're going to be more your lactobacillus acidophilus and all that kind of stuff, which is fine. It's great also from a vaginal microbiota perspective. So just a few brands top of head: Jalna, Chobani, all the major supermarket brands are got sufficient probiotic content. If you want that kind of next level probiotic content, you can go for a kefir, which is more of a liquid drinkable yogurt, which has a higher probiotic content because actually adding it in rather than just using it for the fermentation process, or film yolk, which is very similar to kefir but slightly different. Again, very, very high probiotic content. That can be great for some people, and some people fermented foods is a really big digestive trigger. So I mean, great from a general health perspective, but not always a perfect system. Yeah. Perhaps we can both chime in on this one, Marissa. Young female experiences extreme pain and heavy bleeding during periods, pain only with cycle, has been actively trying to get pregnant for a year. I'm presuming without success, given the next part of the question, has seen many GPs and gynos, has done blood tests and ultrasounds, etc. Recent gyno did not diagnose with endo. What are the next steps to investigate? What do you think?
So I think that it's probably important to look at the types of gynecologists that the patient has seen, because there are gynecologists who specialize in endometriosis. And I think that's really important to maybe see one of those gynecologists. So I think out that way, we can look at, Professor Jason Abbott, Dr. Jason Chow, Dr. Lauren Kite, and Dr. Karen Chan. They're usually the top ones that I know out that way. Stefanie might know a little bit more, but they've got that specialty in endometriosis management. And I think that, we know that you can't officially diagnose without a laparoscope anyway.
Yeah.
So unless the research has changed, but my understanding is you can't diagnose without a laparoscope. And so that would have to be something that probably would be investigated if there were concerns, especially around falling pregnant.
Yeah, I think a laparoscopy with pathology confirmation is a gold standard. I mean, if it walks like a duck, talks like a duck, some people get that provisional kind of suspected endometriosis diagnosis prior to they even get to surgery. And then that surgery is really just the confirmation step, I guess. But I would say a second opinion if this gynecologist did do a surgery and didn't find it. There can be very, very microscopic bits of endometriosis, as we know, which can be, again, just as problematic as, having ovaries stuck and tubes lost in stage 4 endometriosis with a change in anatomy. It can be just as painful to have stage 1 endometriosis, if not more in some circumstances. So stage and pain is not correlated. So it might take a different surgeon or a more advanced trained surgeon to be able to pick that up. And then also we can't exclude things like adenomyosis, fibroids and other things. So it just depends on all the investigations that have been done, but potentially a second opinion might be a consideration. I'm sure that's probably not what the patient wants to hear, but after all that, but certainly would want some answers, wouldn't you? Okay, next question. Oh, this one's sad. I'm sorry to read this. My daughter has undergone 10 unsuccessful IVF cycles. Gosh, the IVF doctor said she had a high natural killer cell count causing infertility and also had IBS, which has no impact on fertility. Another specialist recently performed another laparoscopy after an MRI excising stage 4 endometriosis. Is this a common story? In my opinion, this is highly unethical. I guess this is, I think what you're trying to get at here is more how can people be going through so many rounds of IVF without necessarily having endometriosis excluded? And I think this just speaks to the fact that surgery is required to confirm or deny endometriosis. And it's almost like I almost view it, and it's probably not the right way to view it, but particularly with unsuccessful IVF, I kind of see it guilty until proven innocent rather than the other way around. Like I assume there's endometriosis unless I confirm that there's not by an excision specialist in that particular context, particularly with the number of cycles and the high natural killer cell count we sometimes see a lot of with endometriosis. So yeah, I mean, a lot of specialists do look at laparoscopy a lot sooner than that after a certain number of unsuccessful IVF cycles. And it is very devastating for clients to receive this information after spending so much time, energy, and money pursuing fertility treatments when there was the potential for excision. And we know that there's that improvement in fertility, particularly in the months following surgery and good excision surgery in particular. So it's very tough. And I mean, the ethics of fertility treatments and all that stuff is a whole different webinar. So, and certainly not something I'm an expert on, but I mean, I really feel for you. Yeah. Got rid of about 5%. Yeah. And I mean, sometimes as well, like the laparoscopy initially done only got rid of 5%. And I think that speaks to like choosing a surgeon with the skill set to deal with the endometriosis that's predicted or potentially predicted, and sometimes multiple surgeries might be needed in a short time frame because they need to call upon a colorectal surgeon or they need to call upon a urologist and other people to make sure they're taking care of the other organs. But yeah, really sorry to hear, and my heart goes out to your daughter as well. It's really tough. Got another last question. If a patient doesn't experience pain during intercourse, pain of their menstrual cycle, does this rule out endometriosis? In my opinion, no. No, definitely not. I have seen a huge number of clients who've just presented with fatigue and asymptomatic. I've had people just infertility, otherwise asymptomatic, but sometimes we overlook that infertility is a symptom of endometriosis.
I've had a patient only get diagnosed because they had appendicitis.
Appendicitis, yeah, that's another one. Yep. Do patients with uterine polyps have higher risk of endo? Fibroids, again, estrogen linked, whether that's always consistently linked with endometriosis, I'm not too sure off the top of my head. Polyps in general, I'm not too sure. Do you know anything about that, Marissa?
I don't, unfortunately.
No, probably more gyno question. Yeah, probably a medical question. All right. Well, we are way over time. So if you would like to connect with us and ask any more questions, you can find me on social media, _dietologist on Instagram, and endo.dietitian, which is my endo nutrition focused page. Yes, I'm crazy enough to have 2 Instagram pages. You can find me on Facebook as well, and LinkedIn, and my website, thedietologist.com.au, where you can refer patients. And Marissa, do you want to shout out your socials for SWP?
Yeah, so Sydney Women's Physiotherapy for both of them, pretty simple. And our website, www.sydneywomensPhysiotherapy.com.au.
Perfect. You will get a copy of these slides. The references are all included for you if you'd like to do any further reading. And thanks so much for coming along. We appreciate you being here for this Women's Health Week.